Standard Occlusion Theory for TMD. I am Sotokawa, a dentist practicing in Morioka City, Japan. This theme covers the occlusion theory essential for treating temporomandibular joint disorders, organized into the following 24 topics. This time, I will explain the 12th topic. Examination and diagnosis for occlusal equilibration. 12. Examination and diagnosis for occlusal equilibration. Contents. 1. Symptoms of occlusal disease. 2. Examination and diagnosis of occlusal disease. 3. Exclusion diagnosis of occlusal disease. 4. Methods of occlusal analysis. A. Occlusal interference in centric relation. B. Occlusal analysis between centric relation and intercuspal position. C. Occlusal analysis in mandibular lateral position. D. Occlusal analysis in mandibular protrusion. 1. Symptoms of occlusal disease. The primary symptoms of occlusal disorders include pain or discomfort in the temporomandibular joint and surrounding areas, limited mouth opening, pain or noises when moving the jaw, headaches, and dizziness. Furthermore, symptoms of occlusal disorders range from mild discomfort to excruciating pain so severe that death seems preferable. This wide variety of symptoms exists precisely because occlusal disorders encompass multiple distinct conditions. Therefore, examining occlusal disorders requires identifying the pathologies and causes of the multiple conditions within this umbrella term, necessitating a detailed understanding of their symptoms and severity. Consequently, examining patients suspected of having occlusal disorders requires not only checking for the presence of symptoms but also thoroughly investigating their type and severity. Only then can a diagnosis be made. 2. Examination and diagnosis of occlusal disease. When occlusal disease is suspected in a patient, we perform occlusal analysis, which includes various examinations such as a medical history interview. Through occlusal analysis, we can confirm the presence and location of malocclusion, as well as the condition. Next, we investigate whether that malocclusion is the cause of the patient's occlusal disease. If it is confirmed that the patient's occlusal disease is caused by malocclusion, we plan causal therapy aimed at resolving that malocclusion. As a result, the patient's diagnosis is confirmed. The dentist explains the diagnosis and treatment plan to the patient. Treatment for the occlusal disorder begins only after obtaining the patient's consent. 3. Exclusion diagnosis of occlusal disease. An exclusion diagnosis of occlusal disease, indicating no abnormal findings in occlusal analysis and thus ruling out occlusal disease, is necessary for patients suffering from other conditions easily mistaken for occlusal disease. This is because demonstrating the patient's normal occlusion prevents the error of misdiagnosing and treating occlusal disease, while also providing a basis for referring the patient to the appropriate specialty. Specialties to which patients may be referred include psychiatry, psychosomatic medicine, neurology, and otolaryngology. The referral letter must clearly state the findings and rationale supporting the conclusion that the patient does not have occlusal disease. 4. Methods of occlusal analysis. Occlusal analysis can be performed within the patient's oral cavity. However, to obtain detailed occlusal analysis information for establishing a treatment plan, occlusal analysis performed on models mounted on a semi-adjustable articulator is indispensable. This time, we will explain the methods of occlusal analysis based on the following items. A. Occlusal analysis in the centric relation. B. Relationship between centric relation and intercuspal position. C. Occlusal analysis in the mandibular lateral position. D. Occlusal analysis in the mandibular anterior position. 4. Methods of occlusal analysis. A. Occlusal interference in centric relation. The centric relation is the most appropriate position of the mandible for the temporomandibular joint, controlled by the joint itself. In normal occlusion, when the mandible is guided to centric relation and the teeth are brought together, multiple teeth make contact and remain stable. Furthermore, the deviation between centric relation and the occlusal contact position is minimal or non-existent. Conversely, when premature contacts exist in centric relation, as shown in the upper right illustration, the mandibular condyle deviates from the centric position in the condylar fossa when occlusion occurs in occlusal contact position. Conversely, when the mandible is guided into centric relation and occlusion occurs, only some teeth in the upper and lower arches make contact, while others do not. Centric relation occlusal analysis involves identifying and recording the contact points indicated by the red circles in the upper right illustration. B. Occlusal analysis between centric relation and intercuspal position. The upper right model shows the mandible guided into centric relation. Generally, when a patient's mandible is guided into centric relation, the midlines of the upper and lower jaws align. Afterwards, the patient is instructed to bite down firmly to establish the occlusal contact position. If no anterior-posterior deviation from the midline is observed at this point, and the centric relation and occlusal contact position coincide, this is considered normal. However, after instructing the patient to bite down firmly, the midlines of the upper and lower jaws may become misaligned, as shown in the lower right model. In such cases, we confirm the direction and millimeter displacement of the occlusal contact position relative to the centric relation. The analysis of the occlusion between the centric relation and the occlusal contact position involves measuring and recording the existence, direction, and distance of this deviation. For example, record it as the occlusal contact position is deviated mm in the direction from the centric relation. C. Occlusal analysis in the mandibular lateral position. Individuals with normal occlusion can bite through thread or meat by contacting the canine teeth on the side where the mandible is moved laterally. However, as shown in the upper right diagram, individuals with occlusal interference in the mandibular lateral direction will not have contact between the incisal edges of the working side maxillary and mandibular canines when moving the mandible laterally if occlusal interference exists on the balancing side. Conversely, as shown in the lower right diagram, if occlusal interference exists on the working side molars when moving the mandible laterally, the incisal edges of the working side maxillary and mandibular canines do not make contact. As these examples illustrate, when occlusal interference exists in the mandibular lateral direction, contact between the working side canines cannot be achieved. D. Occlusal analysis in the mandibular protrusion. In normal occlusion, as shown in the illustration on the right, when the lower jaw is protruded forward, the incisal edges of the upper and lower front teeth make contact, allowing the patient to bite through noodles and similar foods. If occlusal interference exists in the anterior mandibular position, as shown in the illustration on the bottom right, When the lower jaw is protruded forward, the molars make strong contact while the front teeth do not. Consequently, the front teeth can no longer bite through noodles. It also induces nocturnal bruxism and causes dysfunction in the lateral pterygoid muscles. The occlusal analysis for mandibular protrusion involves identifying and recording the molar contact points marked with red circles in the lower right illustration, which are preventing anterior tooth contact when the mandible is protruded forward. Standard occlusion theory for TMD. 12. Examination and diagnosis for occlusal equilibration is now complete. If you enjoyed this topic, please click the like button. If you have any questions or concerns, please write them in the public comment section below. The next topic is the 13. Method of occlusal equilibration.